Thank you very much, Damien, and thanks again for the great invitation. This work has been supported by several charities in the UK and in the US. We all know what the problem is. The ideal valve replacement on general conduit and patch that we use in congenital heart surgery and in adult cardiac surgery does not exist. And I always put this example of this baby, and I got that picture. The mother wanted me to hold him for some reason. I was very embarrassed by that, but she insisted. And this is a baby with the interrupted arch truncus arteriosus. It's a good example of a case where we put so many patches to reconstruct the arch, to separate the truncus, and to then connect the RV to PA using, in this case, a contiguous graft. Now, it's not surprised that this baby then is growing up. So as we know, the survival of this operation has improved a lot, but he's at his third sternotomy now. We as a surgeon know this very well. I think you cardiologists are now going to find out how depressing it is to see all these patients coming back over and over again when you put a valve and the valve fails. And this will affect you a lot, I'm sure, in the future, as much as it affected us, because the material we use, of course, cannot last. So is stem cell tissue engineering a possible answer to this problem? We embarked in this 5-year project trying to be practical. There are obviously very good cells to use in cardiac surgery in general for regenerative and for tissue engineering, embryogenic stem cells, induced pluripotent stem cells, but these, for practical and ethical reasons, are very difficult to use in our field. So we took the approach of using tissue that we call perinatal tissue, which you can harvest before the baby is born or after the baby is born, or after the first palliative procedure. So you can take cells from the amniotic fluid, of course, for the umbilical cord, umbilical blood, and when you operate for palliation, for example, you can take cells from bone marrow, thymus, and other tissue that you can then use to grow the cells. Then you differentiate the cells, and then you use a bioreactor to grow to see the cells onto tissue that you then are going to use for the corrective surgery. And this is a technique that we have been using, and we have been testing different materials, and I presented this data last time at PICS. The cells are growing very well on the material. This is the histology at 2 weeks and 5 weeks. Then you put the cells in dynamic culture. This is the bioreactor, and you get a better growth of the cells and the layers. And then you need to prove that these are actually endothelial cells and smooth muscle cells. And then you have this final product. It's a patch which can make as a conduit. And then you have to prove the concept in an animal model. Now, to develop this model is not easy because these are survival models. So you need to choose a model which is the least possible invasive as you can. And so we use 2 types of models. One is the replacement of the pulmonary artery here, where we literally cut the left pulmonary artery through a left thoracotomy, and we interpose the tissue engineering graft. And the other model, which is a bit more complex, is the transannular patch that we do for tetralogy of Fallot. Now, this is the graft which has been implanted in the LPA as an interposition graft. And then this is the other model through medial sternotomy. And then you have to go on bypass, and on the beating heart, you perform a transannular patch, trying to reconstruct the pulmonary valve as well. And again, this is a bit more tricky in terms of survival. We tend to use piglet around from 5 to 10 kilos. So again, these are very delicate animals. And I just show you now, this is the data, novel data coming up in the last few months. After 6 months, you do an echo. We can now do also MRI. We have a new MRI and angio suite in Bristol. to do this work. And I have to say, last year we spent a sabbatical at Rush with Damien. We have developed this model in the animal lab at Rush, and this has been really a great place to work because they have a really good angiocat at Rush. So you do the echo, and this just show you this is a cellularized graft. You can see the right pulmonary artery, the left pulmonary artery here. It's actually 1.5 centimeter. So you feel that this vessel is growing. Now, obviously, Professor Yakub has explained to you that we tend to believe what we want to believe, because my theory here is to try and prove that this vessel is actually growing. So with the eyes of faith, I can think this vessel is actually growing and there is a good flow. When I compare this to the non-seeded control graft, the left pulmonary artery is smaller, 0.5 millimeter, and possibly with a higher flow. But again, this is not really, as Professor Yakub said, we could really want to believe our theory, so we're trying to push our theory through. But then when we explanted this graft, we saw that in the this is the seeded graft, and this is the control. This is the normal pulmonary artery, and the graft histology does resemble quite closely the control, the positive control of the left pulmonary artery, while the non-seeded graft is a much thinner layer. And maybe even better is the electron microscopy. This is non-seeded graft with very scattered network of endothelial cells and very few smooth muscle cells. But in the seeded graft, we have an histology and also a microscopic, electron microscopic picture, which is very much close to the positive control. Now, this is for patients that you can make diagnosis fetally, so you know that when they're born, you can take the cord and start growing the stem cells. But we also have been concentrating on another type of cell. They're called pericytes, and they are really an abundant fraction of cells presented mostly in the vascular structures. And we've done lots of work on pericytes in the UK in terms of regenerative potential. But we now discover that these cells are actually excellent for tissue engineering for vascular structures. So we've been isolated pericytes from samples of patients, either atrial samples or ventricular samples or bone marrow samples. And we have then differentiated these into endothelial cells and smooth muscle cells in a very high number. These are all the pathologies that we have taken samples from. These are just a differentiation in a different type. There is a possible potential of these cells as in terms of regenerative, but at the moment we're using them to try to tissue engineering valves and conduits. This is the cells growing in the matrigel. And this is the endothelial differentiation. Just go quickly through this, a smooth muscle differentiation. And then we see them on the matrix, and they're seeding very well within the thickness and the wall of the matrix. And the interesting thing is that these cells are producing collagen, so they can contribute to the de novo formation of extracellular matrix in the tissue that we are implanted. And the other interesting thing is that they can promote angiogenesis. Finally, another very important thing, our valves, our leaflets fail mainly for calcification. And when we implanted these cells in the tissue, we didn't find any calcified foci compared to the control. So our theory is that these cells possibly put in scaffolding can prevent what's the main problem for valve degeneration, which is the calcification. When we applied for a BHF grant for this technique, they came back to us and say, you cannot possibly grow live cells into a gluteal dyed fixed valve. And in fact, we sent this picture back, say that we did manage to seed live pericytes into a gluteal dyed fixed valve. So the possibility also to regenerate tissue which has with gluteal dyed with these cells is important. Now, this is a nuclei, a residual cell material in a glutaraldehyde leaflet. And this is possibly why these cells calcified, because they are not completely decellularized. They still have the cells there, and these are foci for calcification. So we try now testing different material to seed them with parasites. And this is just a technique that we have developed at Rush. It's been really interesting with Damien. Here we are in the cat lab. We make a small subxiphoid incision in this, I think it's 20 kilo pig. We pass a spur string at the apex of the right ventricle for introduction of the valve. This is the introducer. This is Tom, the lead technician in the cat lab, who really is helping us a lot to develop this model. So you're very familiar with this. We pass this big introducer in the RVOT, which it proved to be quite straightforward and a very minimal invasiveness in this pig model, which is essential if you want to survive this piglet. Then we take this stent, sorry. Then we take this stent, it's a bioresorbable stent, which we use for creating valve. Then we take our material and we create, I don't know if this is working, no, sorry, I'm going back. So again, we pass a purse string in the right ventricle. I'm not sure I can go forward, but so we pass the introducer again. So the bioresorbable stent is actually taken from a company in the Czech Republic, and is actually a stent used for the esophagus, because we couldn't find any company creating bioresorbable stent for a large RVOT, and that was the main problem. So we use this stent, and within the stent we create a pulmonary valve. This is the valve that we use. You can create a B-leaflet or a 3-leaflet valve, and the valve, of course, is seeded with the parasites, or we have the control one non-seeded. This is a bi-leaflet valve. Then we cover the stent with the matrix, and this is the end product. I think this is Damien's hands showing how nice this valve is. And then we do an angiogram, measuring the size as you do in the cat lab, and then you inject this valve through this subxiphoid incision. You know, we were quite skeptical, say this is not going to work, but actually we delivered the valve, we inflated the valve, and on the angiogram there was a good competence of the valve in the RVOT, and we did echo picture shows this bileaflet valve is good competence in the right position. We then explanted the valve, and just this was not a survival model, so we explanted the valve to see what it looked like. So I think in conclusion, I think this is an exciting model we feel, and really if we can create this tissue valve, this valve which are tissue engineered with the patient's own cells, we hope that this can create a valve that not only can last longer, but potentially can grow with the child. I have to thank you, lots of people here helping us with this research, especially the Giving Heart Foundation is a very small charity in Chicago. They helped us a lot to develop this model. And of course, with Damien and Z in Rush and Dr. Kominsky for the cat lab, for the animal lab, we have been able to develop this model. So thank you very much for your help. Thanks a lot.